Armstrong at Lakeview Health. I'd like to welcome everyone to part 3 of our SBIRT webinar. This one is entitled Use and Impact of Technology to Deliver Community-Based Prevention. And I just want to take a minute to tell you a little about Lakeview Health. We are a complete health and wellness program, and we believe in life balance. So we treat the whole person, mind, body, and spirit. And I'll let you read the other things that we support. We have embraced servant leadership, a servant leadership culture, and our CEO, Roy Serpa, brought servant leadership to our community here, and he supports and empowers our staff to act as a tool for families and individuals struggling with chaos and pain. And also, another aspect of servant leadership is the idea that if the executive leadership team takes care of all of our staff and puts them first, they will in turn take care of our patients. And we do see that that really makes a difference. We are an adult-only residential treatment program in Jacksonville, Florida. We're abstinence-based, and we have a medical model, so we have a detox facility on our campus. And we invite you to learn more about Lakeview Health by visiting our website at lakeviewhealth.com. So next, we just have a few little housekeeping items to take care of. Please be sure you complete your online evaluation so that you may receive your certificate of completion. You'll have a chance to do this directly after the webinar concludes. Also, 1 hour after the webinar ends, via email, you'll receive a survey. So you can look for that. An hour after we conclude, all the certificates will be emailed to you. And if you're sitting in an office right now and you have other staff members with you who are watching and listening, but they did not register, if they want a certificate of completion, they need to contact Donna Mahachik at dmahachik@lakeviewhealth.com. So that email address right there is where they need to go. And we'd also like to say a very special thanks to Drug-Free Duval today and Collaborative Planning Group, who are both bringing this wonderful presentation to you. I'd like to introduce you to Keri-Lyn Coleman, who is with Collaborative Planning Group. And Keri-Lyn received her BA in Criminal Justice and a Master's of Social Work from the University of Georgia. And she's the founder of Collaborative Planning Group, LLC, and president of Collaborative Planning Group Systems, Inc. She provides nonprofit organizations and coalitions, corporations, government agencies, and communities throughout the United States with valuable evaluation, strategic planning, and fundraising assistance. She's also worked as a consultant to organizations across the country at the local, state, and federal levels. So we're very excited to have her with us. Then I'd like to introduce Susan Pitman with Drug-Free Duval. And Susan, as you can see from this photo, she's a very passionate person, has a passion for health and wellness, having experienced firsthand the devastating effects of drug and alcohol abuse. She was instrumental in founding a community coalition in Jacksonville in 2008, which supports prevention. Today, Drug-Free Duval has over 1,500 members who are dedicated to freedom from substance abuse for all. She's very committed to changing the culture regarding alcohol and substance abuse. So, Susan, without further ado, we'll let you get started.
Thank you so much, Katie. Thank you for the opportunity that Lakeview is giving us to share this exciting journey that we've taken. It's really an awesome opportunity to tell you how our community has come about making a decision to engage the SBIRT tool and why it's so much more, first of all, it's a prevention tool, and why it's something that we just think is going to explode in so many areas. So we really, really appreciate you giving us this opportunity to reach people, wherever they happen to be through the webinar. And Can't wait for you guys to hear from Keri-Lyn. Everything Katie said in the bio portion is true, but she also was the interim director of the drug-free communities at a very tender young age, and she is brilliant and has brought such support to community work. Drug-free Duval would not be where we are today if it wasn't for the support and help of Collaborative Planning Group and Keri-Lyn Coleman. So with no further ado, we're going to talk a little bit about use and impact of technology to deliver community-based prevention, specifically using the SBIRT model. And today, let me go to the actual slideshow for you guys. Basically, in our agenda, we're going to go over these broad areas. We're going to help you understand how we identified the need to even engage a tool like this. We're going to talk about how important community engagement and the marriage and nexus with technology is. We're going to talk about the SBIRT system itself, not some of the technical things you've done before, but this specific SBIRT system, and then what that's meant, both on a broad range across the nation and then specifically to Duval County at this point. Just to tell you a little bit about Duval County, we are the largest land mass county in the entire United States, and we're a consolidated county and city. So what is also our city, and that's really great in some ways because we have basically one government. However, that one government has 19 council members. So as you can imagine, trying to impact and affect policy change is real difficult. Just there's such a broad range of ideas, and if we had a bunch of small cities, it's very likely we might be able to do some more on the policy side. But one of the things that we had to do in Duval County was determine if we had a need at all. So we started by looking at some national data. And when we look at the national data related to substance use, this is based on 2015 data, you can see that about 10% of the population has misused substances in the past month, the last 30 days. We consider that current use. And if you look at this table here, what is called RX is actually the misuse of a prescription. So it's not people that are legitimately using a prescription of pain med the way a physician has prescribed. This is actually misuse of prescriptions. So it's a pretty large amount of people in the United States, and we have a very similar number here in Duval County. So then we looked at alcohol use. That was various the illicit use of drugs or illicit drugs. So with alcohol, as of 2015, we had about 138 million people across the United States that were using alcohol in the last 30 days. That's, they reported that on their surveys. And about 67% of those, or 67 million, are binge users. And binge users are people, as you know, that drink frequently, 5 or drinks more at one sitting. And of those, 17 million are heavy users. That's defined as binging on 5 or more days in the past month. So 5 or more days in the past month, those heavy users were using at least 5 drinks or more at one sitting. Then we take a look at the number of Americans that are actually facing a substance misuse disorder. And about 8% of our population has a diagnosable substance misuse disorder, substance use disorder. And of these, nearly 13 million experience both alcohol and illicit drug disorders together. So they're actually like a dual diagnosis within addiction. In the past year, as you can see, only 8% of those age 12 and older who were misusing or dependent on alcohol actually got treatment. So we have a huge number of people that weren't getting treatment. 92% of our folks are not receiving treatment, although they're facing a disorder. And you think about that, translate that into something like diabetes or cardiac issues or asthma. If we had 92% of our folks untreated with those kinds of medical disorders, we would, first of all, we'd be a very sick nation, and secondly, we'd be really facing some employment issues and productivity issues, et cetera. Well, guess what? We are doing that when it comes to substance misuse disorders. And one of the big problems that we came across is the perceived need for treatment. because of the 19 million people in need of treatment, the vast majority, 95% of those folks, didn't even perceive that they needed treatment at all. So if 95% of the people that are suffering from a particular illness don't even think they need treatment, we've got some kind of an issue going on. I hope you guys see that the same way that we do. So then we started taking things down to our community level. Our numbers on all those issues are very similar. But we started looking at the impact, what was happening in our community. So we have some more current numbers, as you can see here. We're looking at 2015 and 16 specifically on the escalating overdoses of all substances. And obviously, as is the same across the nation, we have a vastly quickly escalating heroin and fentanyl problem. Our overdose transportation costs alone went from $1.8 million in 2015 to $3.4 million in 2016. And as you can see, the estimate exceeds $4.5 million for this year, which we're not sure where it's going to end up, but that's the estimate. You can see a shocking increase in overdose deaths from a 16% increase between 14 and 15. That's for all overdose, but 106% specifically in the heroin and fentanyl area. Our 2016 numbers are still pending from our ME. And across the board, as we've done both focus groups and surveys, no one wants to talk about it. They're hesitant to talk about substance misuse. They're hesitant to share if a family member or themselves are suffering from anything. They don't want to seek treatment. They're afraid that they might lose their job or someone won't care for them in their community, or even a family member will shun them. And we have, by doing some employer work and employer surveys, we've found that employers really are not supportive to individuals in treatment and recovery. So at the end of the day, as we began to really go through this exercise, we said our community needs specifically are that we need to earlier identify these risk behaviors so that we can prevent people moving into abuse and addiction. We need to help people identify that they actually have a substance misuse disorder, and we need to help them understand that there's help, that they can get help, and that it's treatable, and that they need help, they need treatment, they can be better. And overarching everything is the need for destigmatization, because nobody's going to seek help if they're not willing to talk about it. So what kind of solution could we come up with? We needed something that would help us prevent, destigmatize, assess, intervene, and treat. It's a lot of things that we're looking for in a simple tool. Well, we came across screening, brief intervention, and referral to treatment. You guys, if you've been on any of the other webinars, you know that this is a tool that's approved by SAMHSA, and it's been around for a long time. It has been traditionally offered as a paper assessment, and it's a question tree, but it comes from the assumption, it was developed with the assumption that drug and alcohol dependence are preventable and treatable, and they're public health problems. It's an effective public health strategy to screen, to identify, to intervene, to refer to treatment. We really were intrigued with it because it's universal. It's absolutely universal. Youth can be screened. There's a youth tool. There's an adult tool. Youth can be screened. Adults can be screened. It can be through a primary care physician. It can be through a mental health provider. It can be through an emergency department, etc. We like it because if it's applied correctly, it could be proactive, providing prevention and early intervention. If we apply this tool with everyone, like in the primary care setting, then we begin to use it as a prevention tool. By using the tool and making it more common, we create awareness, education, teachable moments. We begin to increase intervention and treatment access. Obviously, risk decreases, we have increased protection, improved health. But let's really think about it, because the more that SBIRT just becomes part of our regular primary care, then we can just open up the conversation of substance use and substance misuse disorders as part of wellness. So we said, is this a solution for our community? Well, risk behaviors, yep. Check. Early and consistent identification through the use of this tool. What about facing our untreated substance misuse disorders? Yes, because as you'll see, it provides immediate intervention or referral to treatment. And can it address the low perception of need for treatment? Well, absolutely, especially if we can widespread implement this tool through primary care, through just a host of community agencies, et cetera. It begins to reduce stigma and becomes part of wellness, like we said. But here's kind of our picture. If you went to your annual exam and you got on the scale, which we all hate to do, and you got your blood pressure taken, and you took your SBIRT, it was just part of the entire health assessment, then we really have begun to decrease the stigma that we're all experiencing across the nation. Yet we had a barrier or two. The barriers were, as we really began to look at SBIRT, that the implementation was time intensive, because remember I said it's like a question tree. So if you answer yes on question 3, you might have to go to page 5, question 2. It is awkward and bulky for that same reason, and it's expensive because it's time consuming. So if a practitioner is having to spend a significant amount of time, it's expensive. And actually for a long time it wasn't reimbursed. I'm going to pass this over now to Keri-Lyn, who's going to, let's see, maybe. Hold on just a second. Sorry, guys.
Susan, do you need Keri to help you?
Yes.
We're passing it over.
We're passing it over.
Okay, thank you.
Did it work?
All right. I think so. Are you all seeing my screen now with our opportunity?
Yes, ma'am.
Okay, perfect. So as Susan was talking, we really see SBIRT as, and the expansion of SBIRT beyond the physicians and the healthcare organizations throughout the community, and that's why we really have been pleased to partner with Drug Free Duval and other coalitions, because they have community contacts, not just with healthcare, but also with the treatment community and schools and juvenile justice, et cetera. So we really see the expansion of SBIRT as an excellent opportunity to have an important impact. One important piece is that there is a lot of research behind this strategy, and so we are trying to promote it based on the fact that it has a lot of research. Our goal is to see annual universal screening for substance use disorders throughout communities. We know that if we can address behavioral health disorders, particularly substance abuse, we can see improved health at the individual and population level. We can reduce healthcare costs, and then we can achieve positive outcomes not only for the individual, but for their family and then the community in addition. There's some research out there that shows that individuals who are suffering from one of the 5 chronic diseases, such as heart disease and diabetes, if those individuals have an underlying behavioral health disorder, it is twice as expensive to treat that individual. So many physicians are treating the diabetes, they're treating the heart disease, but they have never asked those questions about substance use disorders. And so we want to see that they ask those questions and then have a protocol like SBIRT to address those issues, get those people into low-risk use patterns and or refer them to treatment so that we can address the underlying condition and see reduced costs and improved health, again, both for the individual and for the community. So as I mentioned, we really see this as the ability to have a new target population. So much of our time and attention and dollars have been focused on the treatment of substance use disorders. So the person has gone through their life, gone through the continuum of use, often starting at a young age and then increasing their use and eventually becoming where they are, have a diagnosable abuse disorder. What we see with SBIRT and what we want to do is catch that individual prior to becoming dependent on a substance. We want to catch them when they're in that high-risk pattern where it's easier and less expensive to get them to change their behaviors and move into a low-risk pattern. So at the population level, risky drinkers and other substance users incur more adverse consequences than even the high-risk users because there's so many of them, or excuse me, than the dependent users because there's so many of them. And so we, again, want to target those high-risk, non-dependent substance users and give them some behavior modification strategies so they can move into the low risk. And of course, there will be a portion of individuals who we screen who are in need of treatment, and we want to get them to the appropriate treatment. And you know, and the first step is to help them identify that they are in need of treatment. As Susan mentioned, 95% of individuals who are in need of treatment don't even recognize that there is a need. So we are working with Drug-Free Duval as well as other coalitions throughout the country to partner with organizations, not just healthcare organizations, but schools and emergency medical workers, social workers, child welfare workers, etc. We have an excellent project where we're working with child welfare, where they are training their intervention teams on doing an SBIRT screen. So anytime a new family comes into the child welfare system, they're doing an initial screen for substance use disorders. Shockingly, most individuals in the child welfare system have not been trained in substance use, and they have no tool to identify substance use as an underlying condition. Yet we know that many cases of abuse and neglect are a result of substance use disorders. So trying to disseminate the SBIRT protocol and model throughout a community is going to help not only the individuals who are suffering, but also the children that are dependent on them and the families that they operate in. So again, the important piece, though, is to recognize that this is, you know, it can sound a bit overwhelming that we want to do universal screening, but we recognize that 75% of the population is either abstainers or low-risk drinkers and non-drug users at all. So 75% of the population, if they were screened today, would screen as a negative screen in that they would not screen in need of intervention. And what we do with those is to provide positive feedback. So again, that's where the prevention tool comes. We've raised their awareness that this is something that they should be kind of aware of, and that they are practicing low-risk behaviors currently. So that's 75% of the population. About 20% of the population falls in that mild to moderate risk. So they are, this is the group that I believe SBIRT was really designed for. So that 20% of the population who are high-risk, non-dependent users, we can identify them and then hopefully through some behavior modification move them into the low-risk category. And then about 5% of the population is really already dependent, and so they are in need of specialized treatment. And again, through the SBIRT protocol, we can identify those individuals and make sure that they're connected with the appropriate treatment resources that they need. So we had, again, been working with communities across the country for years, and we were approached by a community collaborative in South Florida who was interested in beginning to implement the SBIRT protocol throughout their community. So we worked with them, and as Susan mentioned, there were several barriers to that implementation. One of the things that they wanted at the community level was to be able to track some of the aggregate data that they were finding through the screenings. They don't care about the individuals, they don't want to identify individuals, but they want to see what are the trends that are happening around substance use. Additionally, they wanted to give their practitioners and their providers throughout the community an easy way to integrate SBIRT into their everyday practice. So coalitions throughout the state now have been implementing the SBIRT process. So the coalition serves as kind of the hub. They have partnered with us to use our database that I'll go through in a moment. They then partner with local community organizations, provide training on SBIRT, and they give them access to our SBIRT database. Within the database, we use the Assist tool and we use the Craft tool. So of course, screening involves the use of the specific evidence-based questionnaires. we wanted to make sure that whatever questionnaire we integrated into our tool was absolutely, well researched and had lots of evidence behind it. Additionally, we wanted to use a tool that not only screened for alcohol use, but we wanted it to screen for other substances. So the ASSIST was developed by the World Health Organization, and it is used to screen adults. It is available in multiple languages, and within our database, you can screen both in English and in Spanish. We also integrated the CRAFT, which was developed by Boston Children's Hospital, again, well-researched tool, and that is used for children. So you can use it for individuals about age 12 up to age 18. So when you have a license to the system, you have access to this ability to track your clients throughout the process. So not only does it provide the skip patterns and other things that you need in order to do an effective quick screen, but it also tracks your clients or patients through the process. So we can see what is happening with them. Have they completed a consent? Have they done an initial screening? Are they currently receiving some type of treatment? And then when is it required to have a 60-day follow-up? The consent is built into the system, so it is tablet enabled. And they the individual who is going to be receiving the screen will consent before it begins. They can, if it's on a tablet, they can use their finger and draw their signature. They can also use the mouse to draw their signature. So that's all integrated and can be printed out as well so that it is in a paper file for the practitioner if need be. We collect some basic demographic information. So we don't use individual names, but they do an individual client ID. They put in a date of birth and gender and race and ethnicity. As far as the date of birth, if you put in a date of birth that is 18 or under, then like 17 and 364 days and under, then the system automatically takes the practitioner into the CRAFT tool, which is the youth tool. And then if they are 18 or older, they are automatically taken into the ASSIST tool, which is for adults. Additionally, we collect the zip code of the individual, and this is used at the county level or the kind of larger organizational level so that you can start looking at how many people are screening high risk by zip code. So are you seeing a large number of individuals screening high risk for alcohol use or marijuana use in a particular zip code? And then that will help with program planning and other assessment purposes moving forward. This is just a screenshot of the ASSIST. As you see, it has the question here, and then it asks, have they used these substances? It lists the substances. In the ASSIST, if you answer yes, that you've used any one of these substances in your lifetime, the next question asks, have you used them in 30 days? So if you answer no to any of these substances, those will drop off of the questionnaire in the system. Where, as Susan mentioned, if you're using paper pencil, you've got to kind of remember what did they answer yes to. Within this system, as they answer the questions, those questions kind of follow them through and has all the skip patterns integrated in. I'm not going to go through all of the questions, but once you go through an ASSIST screening, then the system automatically calculates the score, and then we color code that score so that it gives the practitioner as well as the patient a very quick assessment of what is happening and where the concerns might be. So if they are at high risk, it shows in red. If they are at moderate risk, it shows in yellow. And then if they are at no to low risk, then it's shaded just a gray. And again, the practitioner can print this out and give it to the patient so that they can take that home with them or take it if they decide they are willing to do some treatment or if they're in need of treatment. They can take that screening result to the treatment facility or to the practitioner who is going to help them with brief therapy or other interventions. So again, the great thing about the system is that not only does it give you some very quick ways to use it at the individual level and for the practitioner, But at the community level, you can start running reports to see what's happening. Again, at the community level, you only get aggregate data, so it's not like they can see individual results. But instead, they can see things like how many clients were screened, how many passed or failed to pre-screening, and then what has happened with those individuals. Additionally, within the system, you can filter the information. So if you wanted to see, for example, how many males or females were screened, you would filter by gender, and then you would see the results just by the gender that you've chosen. You can also do it for race, ethnicity, and zip code. So it's a great way to instantly access some of the community data based on the screens that have been conducted in the system. So in addition to making it easier for the practitioner, there are some recent studies that show that patients, especially youth, would rather complete an e-screener than begin their discussion with a professional. So if you can hand them a tablet in the waiting room or before you begin working with them, they can go through the screen on their own if you just kind of set it up for them. And then when you see the result, you can discuss the result together. It can allow people to answer the questions at their own pace and think about what they're doing as they go through it. And as I've mentioned, the technology solutions allow communities to get a clear picture of their substance use needs and patterns. And so with our system, they can run a variety of reports to see what's happening within their community. And then additionally, within the system, if they have screened positive that they are in need of treatment, we link to the SAMHSA treatment dictionary resource. And so they can they can link to that within our system, put in the zip code, and then find the treatment resources within their community that are registered with the SAMHSA website. So it also helps increase a bit their access to follow-up care. Additionally, the organizations that we work with create a list of treatment resources in their community. So it's not just the SAMHSA treatment resources, but also private practitioners and others that are operating in the community. And so that PDF document is loaded into our system so that whenever a practitioner uses our system and knows that they need to find a resource for their client, they can access that and then print off a list of all the resources that have been identified by the coalition that we're working with. So as I mentioned, we are particularly keen on the SBIRT process because we know that it works. We have partnered with 16 counties in Florida to provide the assessment system. As I mentioned before, the Florida Department of Children and Families has partnered with us so that they've trained their child welfare workers in, I think it's 10 counties in Florida, so that they are doing screenings when an individual, a new family comes into the child welfare system. And then we've also partnered with these community coalitions. In 2016, 3,000 individuals were screened using the assessment system. And so, Susan, I'm going to pass it back to you.
Okay.
I got it.
Okay.
Yay. All right, everybody. So now we're going to just look at a couple of amazing results that we've had here in Duval County. These are specific to Duval County. So in the past 12 months, as you can see, we screened 37 adults, and 27 or 73% of those screened high risk at baseline. And that's because we weren't doing across-the-board screening. You know, eventually when we get this implemented across all of our systems and primary care, et cetera, it'll be great. But so 73% of those screened high risk, but of the 24 follow-up screens, so almost all did follow-up screens, this was after the interventions were presented with fidelity, 0 screened high risk at follow-up. From a prevention and intervention viewpoint, this is astounding. It is such great use of very, very limited resources. So we're just really excited about that. And then we also want to talk about the youth, the 282 youth that we have screened to date. Well, actually, it says 282, but 186 or 66% screened high risk at the baseline. Again, because our initial implementation was done with a group of youth that have been identified as high risk. So 66% screened high risk. When I say high risk, they were kids involved in the teen court program. So they had some kind of juvenile justice situation. So 186 of them screened high risk at the baseline assessment, but after the interventions were provided with fidelity, and we had 169 follow-up screens, only 38 screened high risk, which is just a phenomenal percentage. We are overjoyed that the vast majority of these kids moved from a high-risk behavior into low-risk behavior. And I did want to speak about the technical side in terms of community, because as we get the data, we basically can map out on a large map of our county these use patterns in certain areas. So not only do we put out the use patterns, or where we're identifying specific kinds of behaviors related to substances, we're overlaying that with other factors or consequences like youth crime, motor vehicle accidents, health issues, poverty, etc. And so it's enabling us to, as you can see on this particular slide, be kind of the center of a very comprehensive look at all of these social issues that we all know are entirely intermingled. And so we now have data that's very, very significant to everybody from hospitals, Department of Health, juvenile justice, schools, service providers, Department of Children and Families. And the data is really at the center, and this tool is at the center, this amazing tool that isn't just an assessment tool, but it's also a protocol for change. It's a protocol for next steps. So we are, I can't even tell you how excited we are that the SBIRT conversation has risen higher. We, at this point, as a community, want to implement it across all of our systems, as I've said numerous times, through primary care physicians, through pediatricians, through community agencies and groups. And because of the web-based technology and the ease of the tool and the fact that it doesn't have to be a professional practitioner who's actually providing the assessment, we even see this being implemented through community agencies like the Girls and Boys Clubs and sports organizations and things like that. So to show you a picture of where this tool can go, we are going to play a brief video of our sister coalition and the work that they've done down in Broward County. We want you guys to have an understanding of how this really does play an integral role in an entire community, both on prevention, intervention, treatment, and recovery. So hold on while I try to get the video up. Let's see. Here we go. Can you all see this video?
Susan, I can't hear the audio.
Hey, Susan? We can't hear it either.
A nationally recognized, evidence-based, outcome-oriented strategy can be used in multiple settings, easy to implement but very effective.
What SBIRT does is provides the entire community a tool to not only detect but to intervene at an appropriate time in order to create more wellness in the community. At Florida Regional Health Planning Council, we're using the SBIRT tool as an intervention early on in the admission process and throughout the competency restoration training process. We use it as an intervention in order to conduct risk assessments to get a comprehensive view on the substance abuse history, the client history, and to further ensure the client's successful reintegration into the community.
It really does a great job in helping us capture what kind of change you have in the participants that you work with. Also, too, it helps us to determine whether or not our services are effective in a standardized, measurable way.
Our clients have been able to build rapport with our therapists and has been a nice, easy transition into their treatment. Our therapists have been able to easily assess the type of level of care for each of our clients in order to refer in our community. And this has been very impactful for our agency as well.
Using the SBIRT assessment at PACE Center for Girls has not only increased the participation in the girls of their assessment, but it's also helped the counselors and therapists really understand the needs of the girls. It helps us to understand whether they need an intervention or prevention level of services. The counselors and therapists enjoy using the SBIRT assessment. It's quick, it's user-friendly. They're really enjoying the web-based application of the process. The girls enjoy knowing that their scores can decrease from the time they start with us to the time that they end their counseling with us. And when they end their counseling with us and they see that their scores have decreased, they get excited and they know that the hard work that they've put into their counseling and their therapy has really shown.
This assessment has helped Hispanic Community of Florida in the Youth Development Program to lower risky behaviors among youth. This tool is helping us also to increase our education and awareness about alcohol and drug abuse.
One of the benefits that we've seen of using SBIRT with Broward County school students is we've really been able to demonstrate to the students their severity of risk by going through the questionnaire and then printing out the scale that actually demonstrates to them where they fall in their risk and what the appropriate treatment level is. That has really been very motivating with our students to help them to see their need for treatment. We've seen really great results just within the first school year that we're using it.
It is easy to use, friendly, and we find that it's really effective and impactful in making sure that we're doing the best to ensure that Broward County has the top-of-the-line prevention services. It's literally saving lives.
The organizations learn about not only the national evidence-based program, but also our local approach to implement it. In the last year, the United Way Commission on Substance Abuse has been offering free trainings to providers. Our goal is to make sure that they are ready to start implementing SBIRT. If you would like to participate and be part of this collaboration, just reach out to us.
We're always looking for ways to partner. We're always looking for different community actors to come join us in help promoting wellness in our community. Find out more about SBIRT. We look forward to hearing from you.
Okay. Let's see. Keri-Lyn, back at you.
All right.
And now that
Okay, so we believe that we can make a significant difference at the public health and at the population level because this is, as we've identified, it is a large and easily identifiable and accessible group of high-risk substance users. So if we can identify the individuals who make up that large group and then help move them from their high-risk use into a low-risk category, we can just use small changes to have a large effect in communities, in families, and among individuals' lives. Keri, if you want to.
Oh, okay. This is Katie.
Okay.
Great job, both of you. Okay, so we already have a question, and thank you both very much. The first question is, this came from someone in DC, from Kevin, and it says, you mentioned employers are not supportive of people in recovery. What data supports that? I work with an EAP program that is very supportive of people in recovery, and most EAPs also support employees. I think that was in response when you were talking, Susan.
Can you hear me?
Yes.
Okay. Somehow I'm off the actual webinar, but I'm still connected by phone. Okay. Our evidence comes from, we're very involved. We're one of the 6 communities around the country that is part of the Clinton Health Matters initiative. So we've done extensive work with our employers around here. We have a whole employee wellness kind of initiative that we've been working on. And one of the areas, one of the reasons that we have noted this is we've done some surveys, and the benefits related to recovery aren't consistent with the benefits related to recovery for other illnesses. For instance, if an employee had a cardiac arrest and ended up having to do cardiac rehab, there's typically not an issue with having employees miss work a couple days a week to attend cardiac rehab. But if they get out of a substance misuse treatment situation and need to go to a recovery group during work hours, there are less employers that are willing to allow employees to do that. They want them to do that on their own time. That would be one of the issues. Another thing is transportation issues. Often it's really hard to get transportation to and from some of the recovery or even IOP programs or outpatient programs, and there's not a lot of employee support at this time in our area. That's one of the things that we're working on. So that's our evidence for it.
Okay. Kevin, does that answer your question? Oh, right. You can email me. Does anyone else have a question they'd like to type in the text box? We'll give it just a few more seconds.
I do want to say that I know Keri-Lyn mentioned this, but I really wanted to emphasize the reality that SBIRT applied kind of across the board opens up the opportunity to reinforce healthy behaviors is huge, because we don't frequently within the medical setting or community setting or whatever recognize when people are making the healthy and wise choices. It's just once they move into problem behaviors that we begin to really address it. So I think, as Keri-Lyn pointed out, the vast majority of people will present low risk, and to be able to reinforce the choices that they're making and how they're handling stress and what they're doing for stress and stuff is really powerful.
Okay, great follow-up. And Kevin says, thank you, Susan, for your answer. I think that, just to piggyback on that, I think Dr. Hunt, who did part 2 of this training, he mentioned that the statistics show that for those family practices and internists who do utilize SBIRT or one of these other tools, that just the fact that the patient is answering these questions and takes a look at their usage decreased the amount, they were monitoring themselves and really decreased what amounts they were drinking. So, and there's another question coming in. Could you please discuss the cost?
Keri-Lyn, I'll let you discuss that.
Okay. So at the if you're going to implement SBIRT as Drug-Free Duval has, the costs that they bear are the cost to train practitioners throughout the community. Also the cost for, they have an SBIRT coordinator that sits within Drug-Free Duval, and so that person is helping to recruit new providers and practitioners. I don't think that's her full-time job, but that definitely is part of her staff time. So at that community level, the cost is, again, bringing in a trainer or getting trained as a trainer in SBIRT so you can offer training to providers throughout the community on a regular basis. And then having someone who is recruiting new partners and monitoring their implementation and offering support and assistance. And then in addition to that, of course, the cost of the license for the system. We are a mission-based organization, so I really try and make our systems competitive, even more than competitive as far as pricing, so that that we can disseminate this information, because again, I want to accomplish our mission of relieving suffering of individuals more than anything. So we have a basic licensing fee that is about $2,000 a year, and then there are some additional costs for based on the number of providers you have using the system, and then we do packages of seats for the practitioners. So you can get a license for the system for as little as about $2,500 a year, and if you have a lot more users and you need any kind of customization, then the cost would rise from there.
It's a tremendously cost-effective tool for the reach and impact that it has, from our perspective.
Okay. All right. Thank you. We don't see any other questions on our end. So with that, I'd just like to say thank you both to Keri-Lyn and to Susan, and to all of the participants who called in for our webinar today. We're glad to have you. And I want to remind you that you can either complete the survey when it pops up right after we close the session, or in 1 hour you'll receive an email from us with the survey. So that's what you have to complete in order to get your certificate. And thank you so much.
Katie, can I add one thing? This is Susan.
Sure.
If anybody who's listening has the desire to begin to try to implement a community-wide model, we're happy to help. So I think my contact information is on the PowerPoint, and you'll receive a copy of it. So just let us know. We'll be glad to help you with the marketing materials we used, and kind of our talking points, and even letters and implementation and stuff like that. So just
okay, wonderful. And both on the slide that's showing right now, both your contact information and Keri-Lyn's is still visible.
Okay,
so
great.
That's great. Okay. All right. Thank you very much.
Thank you so much for hosting.
Yes, thank
Sure.
you.
Our pleasure.
Take care, everyone.
Take care.
Bye. Thanks so much. Bye-bye.